Well, Lynn, I'm going to try and hold you up there and let Russell
Okay,
get
thank
to
you.
his story. Russell, I'm so glad you could make it. You were uh, not too hard to find, and you kind of volunteered fairly quickly when I asked if you could make a presentation. And I've had so many people say they really want to hear this, and if they can't hear it, they'll be able to watch the recording. We do record all of these meetings, whether it's the 8 o'clock in the morning meeting or the 4 o'clock in the afternoon on the last Thursday. They're all recorded and they go into our library within a couple of hours and maybe a following day. So I'm going to wait for you to give us a brief overview of your role within the Oakland County Health, and then get into your planned talk if you want.
Well, I appreciate the invitation to join you all, and I I've been with Oakland County Health Division for 2 years now. I actually I retired from an active surgical practice 10 years ago at the age of 55. And I was bored, so I ran some companies. I actually ran a healthcare brand strategy and marketing agency for 8 or 9 years. And the prior health medical director for Oakland County was moving on to another position and invited me to come out of retirement to take this position that I, I'd been missing an active role in healthcare, missing seeing patients, and they convinced me that I could make a difference in my community, and that every day would be different and intellectually challenging, and all of the above have been true. It's been a great couple of years, although I picked a bad time to enter public health. But every day is a challenge, and I'm used to, as a surgeon, I'm used to focusing on the single patient in front of me and making life or death decisions that just affect the one person. And it's a little daunting now that I make decisions that affect tens of thousands. So that's taken some getting used to. But as I was saying, we have just a phenomenal team of people that work with us and make me look good. So that's all cool. I've been there 2 years. If I'm there for another 20 years, I might start to feel comfortable. It's a steep learning curve. I suspect everybody's pretty familiar with kind of numbers right now with regard to COVID-19. We have the dubious distinction of being #1 in the world. Woohoo! We're around something like 4.5 million infected here in the U.S. We, as of yesterday, surpassed 150,000 fatalities. And again, that's let's say a dubious distinction. We here in Oakland, actually in all of Michigan, despite the fact that we had early cases and a really steep wave at first, I really have to give credit to our governor for essentially making decisions that were just a lose-lose scenario for her.
Mm-hmm.
She really stuck her neck out and made decisions that were absolutely for the citizenry, for public health, focused on health without regard to the political blowback and the political price that she's paying. I just can't say enough for the things that she's done for Michigan public health. Despite that, we've had an enormous number of cases here. Michigan has seen over 80,000 infected cases. we have over 6,000 fatalities, but the good news is we're coming up on 60,000 recovered. And the recovered number is an important number. Here in Oakland County, we have over 11,000 diagnosed cases, confirmed cases, over 1,000 fatalities, but now we're also over 8,000 recovered. You know, I've got some notes. I just kind of wanted to move through some things, but you know, I think one of the things that will be most value to people, and I'm going to share, I will email a couple PDFs to Phil, and he can share them around. I really wanted to talk about testing methods because there's just so much misinformation and confusion, and you have access to testing at anywhere really. And I want to talk about the method, and I want to talk about diagnosis, and I'd like to talk about what you can expect in terms of value of the result. That is, if you're going to get the result back in 2 weeks, it means nothing. Certainly for public health, it means absolutely nothing if I get the result back in 1 week, because our role is what's called surveillance epidemiology. And what that means is we monitor for cases by testing. And we do that so that we can have a result back, say within 24 or 48 hours. And at that point, we take that individual, we pull them out of the general population, and we conduct a case investigation. Now that case investigation will help determine all those who have been exposed to that individual while they were infectious. At that point, that list of people gets turned over to the trace monitors. So they basically contact all those individuals. They tell them that they need to monitor for symptoms, check daily temperature for fever, that sort of thing. But those are the steps. If we get those test results back in a week or 2 weeks, or oh my gosh, 3 weeks, and we've got labs that are sending us back results in 3 weeks, that's useless. Because without any testing at all, if you're exposed today to somebody who is definitely COVID infected, and you had a close encounter within 6 feet for at least 15 minutes, you're clearly exposed now. What I'm going to tell you to do is to quarantine for 14 days. Why 14 days? Because we know that the latency, the potential latency from exposure to the last possible time that you might become infected would be about 14 days. Yeah, there's a couple rare cases out, you know, at 16 days or 18 days. But basically 99% of the people, if they're going to become infected, once they've been exposed, it's within that 14-day period. So if you've been exposed, I'm telling you to sequester, you're gonna quarantine for 14 days. If I test you today and I don't get the results back for 2 weeks, what good are the results? I could have saved the cost and the hassle of testing and just said quarantine for 14 days. The other challenge is that, as you know, we started out this way back in March. We have limited access to testing. So back in March, there were limited testing platforms. That is, the machines that conduct the test, the PCR machine, for example. And even when you could get the machine, you couldn't get the testing kits. And even if you could get the testing kits to run the test, you couldn't get the swab to collect the sample. Okay, wow. That's back in March. And we're talking, we were, I'm going to try to avoid any political commentary, but the fact is, FEMA was developed to do exactly that for us as a nation. FEMA was developed to go out in times of a pandemic or a national emergency, and it was their job to go out on the global market and basically bid for those supplies. And they just threw their hands up and said, nope, every person for themselves. So we've got states bidding against little local health departments like us, bidding against other countries like Spain for all of these supplies, for swabs, for the testing kits and supplies, for the machines, and for ventilators later on. So that's been a huge frustration. We hit our peak of that challenge back third week of March, and we're headed back there again. And there are many reasons for that. There have been mandates or advisories instructing, for example, nursing homes to test all their employees, all their staff every 2 weeks or even every week. And so there's been this enormous crush on the labs to keep up with demand. Now, there are many labs that will promise you a turnaround in 3 days, and they can't get it to you for 3 weeks. But of course, they're still charging you $100, a test. So that's fairly common right now. We're back approaching that again. I will tell you that Oakland County is now contracted with, let me think, 4 or 5 separate laboratories to try to keep up with the demand. So one of the labs can only accommodate, that is their capacity for us. They can only promise to us, and these are the labs that I can rely on, that are going to be transparent and honest with me. They can only accommodate about 600 tests a week. I can generate 1,000 a day. So this one lab is really our best lab for turnaround. 3 days. They can only accommodate 600 a week. Another lab is out at a week, and they can accommodate about 600 a week as well. A national lab, Quest has been up and down as they try to accommodate, national demand across the country. And, they started out, like most of the labs, they'll start out with a fairly rapid turnaround. And then as the crush, as they become over-obligated, over-committed, it lengthens out. And again, 5 days or more, I can't conduct epidemiology anymore. Anyway, I could rant about that. Obviously, I could go on and rant about that for another hour.
Sounds critical, though.
It is critical. So what I would like to it doesn't add value for you guys, though. And I did want to try to add some value because you all have access to a variety of test methods. And I want to talk about the 3 main test methods that are available right now, and try to give you a sense of whether they're legitimate and whether they can provide any benefit, to you or your families. So the gold standard is the molecular test, the PCR test, polymerase chain reaction test. So the molecular test basically requires a swab, and the anatomic site that they collect that, basically it's a big Q-tip that they collect the swab from, has varied. For a while it was just nasopharyngeal, which is basically all the way back here at the very back of the throat, through the nose, not very pleasant. And that kind of evolved to an oral swab, maybe around the tonsil, back of the throat. That was pretty reasonable, not too bad, gags you a little bit, but not horribly uncomfortable. That evolved to an anterior nasal swab, just about 2 centimeters in, just like that, because the data for a while said that any nasal site was much more sensitive and accurate than any oral site for swabbing. Now they're back saying the oral sites are fine and sensitive. And this reminds me to just toss this little aside in. Everything that we know and say is based on the best evidence we have at this particular time on this particular day, because this is a very, very rapidly evolving area of science and medicine. that is. CDC changes their website every single day. They change their guidelines every single day. And, you know, and we end up having some egg on our face because today I'll be in a press conference and say, you know, these are the guidelines. And tomorrow it'll be something else. So I'll qualify everything I say by saying it's as of today at 4 o'clock on this date. So the molecular test is the gold standard. There are some rapid molecular tests that are pretty accurate. And Abbott makes one called the ID Now platform, or the Abbott Rapid. There had been a lot number provided of test kits that had lower sensitivity, lower accuracy for a while. We have 2 of these machines in our lab at Oakland, and we've validated that test. It takes 15 to 20 minutes to get a result back. And in our hands, in our lab, compared to the State Bureau of Labs and the CDC, it's 100% accurate. So we've had great success with it. The challenge is I can't run 1,000 of them. It's, you know, I sit a technician down at the hood with those 2 machines, and they can give me 2 results every 20 minutes. I can't test the whole county that way. So, but your physicians may have one of these things sitting on the counter in their office, in their clinic, because this particular machine is commonly used to do rapid flu tests, for example, and some other, you know, strep tests and things like that. So you may have access to this through your physicians if you ask for the Abbott, ABBOTT, rapid test. And again, it's a molecular test. It's perfectly legitimate. Okay, I want to talk about 2 other kinds of tests. The antibody test. First off, back in March, there still are, literally more than 100 companies selling a rapid antibody test. And they were falsifying their data. And they were insisting that the rapid antibody test could be used to diagnose COVID-19. They cannot. And that they could be used to clear somebody who had been infected to return to work. It cannot be used for that. And in fact, in my experience, and I've personally tested 3 of these now, none of them are reliable. So that's the rapid antibody test. Here's the problem for all of us. There are cities, villages, townships, there are urgent cares, there are pharmacies that have invested tens or hundreds of thousands of dollars in the rapid antibody test. And they're trying to recover their investment. So I still have people coming to county right now on a daily basis saying, I got this test result because I went to this urgent care, I went to this pharmacy drive-up window, I got this rapid antibody test. I'll tell you, the rapid antibody test is the finger poke blood spot, okay? So that's how you can know it's no good. Just say that right up front. It's garbage. So what they do is they do a finger poke, squeeze a drop of blood on a little card. It looks like a little pregnancy test card. They put a couple of drops of buffer on it, and it's supposed to run out like a chromatographic test for antibodies. It's no good. I'll just leave it at that. I will say this. Virtually all of those companies that are selling that say that they're FDA approved. Not one is FDA approved. Okay. If the FDA were reasonably funded, so as of 2016, the FDA, the CDC, and FEMA have all been defunded. But if the FDA were reasonably funded and competent people had not already resigned, the FDA would be able to go after those companies and prosecute them. By the time they get around doing that, you know, in a year or 2 years from now, those companies will have made their millions and they'll be out of business. They'll be gone. They'll be hanging out on the beach somewhere. Okay, there's another kind of antibody test, and this is called the serology antibody test. And by serology, that means they actually have to draw a couple tubes of plasma. They have to draw some blood out of your arm, okay? So they're going to put on the tourniquet, that whole deal. Draw some blood. It's going to be a red top tube, maybe a tiger top tube, and they're going to spin that down and send the serum or plasma to a legitimate laboratory. And what that lab will do is they're going to do a quantitative titer for IgA, IgG, and IgM to look at those levels. That's awesome. We really want to know that information. But in fact, right now, we don't know what any of it means. That is, I would like to know that somebody with antibodies is immune, right? That they're going to have antibodies to COVID-19 and it's going to be protective. Wouldn't that be beautiful? But we don't know that yet. And in fact, I was on a call last week with CDC, and the pilot data, the preliminary data suggests that the immunity wanes very rapidly. We're talking within months. So the big fear is that if you're naturally infected with COVID-19, it'll be similar to other coronaviruses, which is what we get with the common cold. And that immunity doesn't last. How do I know that? Because I get the common cold every year, and I had it last year. So even though I made antibodies to it, it doesn't do me much good. Our fear is that that may be the case with COVID-19. Now, on the upside, the vaccines that are being developed right now are going to generate immunity that's similar to what's called wild type or natural immunity. They're working on at least 4 different strategies, and they involve, oh my gosh, they involve molecular methods, that is developing antibodies against the RNA or DNA. They involve protein methods of surface proteins. They involve using what's called adjuvants. We don't have to get into all the technology of that. But at least the vaccine technology is promising, and at least I'm optimistic about that. That second type of antibody test, the serology quantitative titers, is perfectly legitimate, but I warn you, you cannot just go to the drugstore and have that done. You can't go to your doctor and have that done. Those are right now official clinical trials. So for example, CDC is running clinical trials right now down through the Detroit Blood Bank. You can go to a blood bank and say, can I get my COVID-19 antibody levels if I donate blood? And they'll tell you whether or not they're one of the participating blood banks. That would be awesome, because then they'll give you your results. Some of the hospitals are partnering with places like the Mayo Clinic. So the fact is, you can't get that second antibody test done without an official clinical trial. It's still investigational. There's still studies. We still don't know what the results mean. There you go. Now, finally, the antigen test. So we got antibodies, that is antibodies that your body makes, an antigen. So the antigen test is similar to the molecular test. It's looking for the presence of virus. So the antigen happens to be a surface protein on the COVID-19 or SARS-CoV-2. That's what it's looking for. Similar to the molecular test, it requires a swab. Unlike the molecular test, all of the antigen tests are rapid. And right now, they're still investigational, but you can get them at urgent cares and pharmacies. All of them, according to CDC, require confirmation through some other method. That other method may be the molecular test, or it may be a clinical diagnosis. That is, if I've got somebody in front of me, man, they've got 5 symptoms of COVID-19, they've got a positive antigen test, I don't have to do anything else. They've got COVID-19. If they're completely asymptomatic and they've got a positive antigen test, well, I don't know. That, it's not that sensitive and accurate. So I would, if I really need to know whether they're infected, I need to get a molecular test. Here is the challenge with the molecular test and the antigen test. That is, if we're looking for somebody shedding virus, that's what we're looking for here. If you got exposed 2 days ago, and the chance, and let's say you got exposed and you contracted the virus, you're infected now, okay? And I test you today with the molecular test or the antigen test. I'm looking for you shedding virus. I can't actually tell whether you're infected or not. All I can tell is whether you're shedding enough virus that I can detect it. That's all I know when I do these tests, the molecular tests, the gold standard. That's all it tells me, is that today you were infected enough that you were shedding virus that I could detect it. And if you got exposed 2 days ago, you may not have any virus being shed. That is, it's just starting to get, just starting to divide in your bloodstream, just starting to get going, but you're not really shedding virus yet. 2 days from now, you may be. So that's the frustration. The molecular tests and the antigen tests are just snapshots in time right now. Here's the other nuance, the other frustration. 2 really important points. The amount of virus that's being shed, that is the amount of infectious virus and the amount of infection risk that you pose if you're infected, parallels the severity of symptoms. So let's say I'm infected, but I've just got the sniffles. That's it. I feel pretty good. I'm not coughing. I'm not wheezing. I have no shortness of breath. I have no fever. I just got stuffy nose. And it's not as if this is uncommon. Very common. I'm not as infectious as the person that has all those other symptoms. Okay? So that's good news. One last frustration is this. Actually, it's good to know. If you are infected with COVID-19, from the first day of symptoms out to about 10 days, you're infectious to other people. But after 10 days, even though you're shedding virus, that virus is no longer alive. I could test you at 4 weeks out and still have a positive test, but it doesn't mean that's live virus, because all I'm looking for is the presence of the RNA. It might be shredded virus, right? Your immune system has kicked its butt, and it's just viral RNA hanging around or viral protein hanging around. I'm doing an antigen test, but it's not infecting anybody, okay? So from the day your symptoms start, you're infectious for 10 days only. And that's why the return to work guideline is a time-based guideline, not a test-based guideline. So after 10 days, it doesn't make sense to get tested again to return to work. It's all about the time. Well, it doesn't look like I put everybody to sleep yet. So a lot of nuance in testing and a lot of misinformation out there. And I will tell you this, I just want to warn you, there are people out there, there are unscrupulous people out there trying to make money on us with tests that mean nothing. So just be warned, and you are always welcome to call us, and I'm pretty sure I have this number memorized. Call the nurse on call anytime, 800-848-5533. Okay, that's the nurse on call for Oakland County Health. And these folks, are kind of brought up to date on a regular basis, like a couple times a day, frankly. The stuff that they have to not only memorize but reference for the wide breadth of phone calls that they receive is pretty impressive. But if they can't answer, they'll move you to somebody that hopefully can. Let me see if there's anything I was supposed to talk about besides testing, which is kind of my favorite topic. Oh, yeah, y'all have kids or grandkids headed back to school probably. I don't know how successful that's going to be. I will tell you that of the 28 superintendents, 24 of them really want to open up again and have boots on the ground, face-to-face class starting, which frankly shocks me. But if I look at it from their perspective, I have to understand that this is not what their teachers do. They don't do remote training, on video or Zoom or what have you. They're going to end up competing with charter schools and private schools in that regard, and I'm sure they're intimidated by that. But I also tell you that the teacher unions, are going to fight this, and they'll have a lot of early retirements and a lot of people that just strike and don't show up. It's going to be a real challenge. And around Oakland County, we're sort of taking bets on how long it will last if schools do open up. Will they last 2 weeks before they're shut down? Will they last 4? I don't know. But based on what we're seeing now, there are going to be some horrendous outbreaks. That is, right now we have teams that are practicing, right? So we had an outbreak yesterday. We had an outbreak the day before in athletic teams. We had 2 the day before. Last week we had an outbreak in daycare and in a like a kindergarten school. They're just coming at us mad and furious right now.
Russell, what's an outbreak to you?
Right. So CDC definition for COVID is 2 cases with a common source or more at a location. Right now we're seeing so this morning we had an entire varsity coaching team put in quarantine. So that was an outbreak. Fortunately, and that one of the challenges for us is that we know we're being lied to. Okay, when we do a case investigation, we say, were you wearing masks? Were you maintaining 6-foot social distancing or greater? Did you spend any time within 6 feet of 10 to 15 minutes? And of course the answer is, oh yes, of course, no. And we know, that we're being lied to, but we can't set guidelines on the basis of trying to rank the probability that we're being lied to in every instance. So we have to take people at face value and move forward. And so taking the coaching staff at face value, none of the kids were exposed. None of them were a close contact. But they've all potentially been exposed, and we'll do, trace monitoring and do very close monitoring. But moving forward, the numbers that we're going to be looking at will rapidly climb into the thousands that will require trace monitoring. And that's going to become a challenge. We've tried to leverage not only across the health division. For example, when things are really, really bad, we start to shut down our clinic. So the nurses that are normally in clinic doing immunizations and seeing STDs and seeing HIV and tuberculosis and all the other things that we take care of in county, they sort of are brought back and put into case investigation and contact tracing. So, we kind of, it's kind of flex personnel and we shift and redeploy. So not only do we redeploy across health, community health, our community health nurses just are trying to stay safe and they're not going into homes now. They used to go into the homes of expecting moms and do education and nutrition and things like this. Now they're doing it by Zoom, they're doing it on phone calls, and we're bringing them back and redeploying. So, we've redeployed across county health, but also across county. And we have, again, we've trained close to 300 now, trace monitors, and again, we have about 20 case investigators. But and the other thing we've done in preparation, because this is going to get crazy coming up here this fall, because we're going to be in cold and flu season and COVID season. And yeah, it's going to be nuts. So what we're trying to do is leverage technology. And so we've invested heavily in technology for apps, so that instead of a trace monitor calling down the list of all the people they have to contact every day and say, do you have any of these symptoms? Have you checked your temperature? Do you have, temperature of this and above? People can just check an app on their phone and answer those questions and move on with their day. So it's more efficient. It leverages technology. We have an online app, and that'll help kind of amplify the number of cases that a case monitor can manage.
Excellent.
Yeah, we
Well,
hope.
you mentioned earlier the quality of testing in the different fashions, and I watch the news, unfortunately, nearly every night, and they keep harping on,
You got to stop that.
get the message, get the test, get the test. So they're lined up for hours and hours and hours, and the tests are probably no good by the time they get home. How can the public be re-educated now to say, we really don't need to do all that testing? And I'm realizing that companies want to make their profit, but it's at an expense that I couldn't get a test quickly enough if it were something I really needed today to satisfy my medical need, because other people are getting tested in such quantities that nobody can meet the demand.
So I routinely take calls, and we have a limited capacity at Oakland County in my own lab. So I run the lab for Oakland County, and we have, about 100 tests capacity daily, and our turnaround is same day. So next day at the latest. And what I end up, what I end up using those 100 slots for is I'm testing jail staff, because we really cannot afford to have COVID-19 killing everybody in the jail. So that's I think a worthy investment. When inmates come into the jail, they quarantine them for 2 weeks. And at that point, I test them before they're released in the general population. I think that's probably a worthy investment of a test. But in addition, I take regular calls from folks like yourself, from families, telling me that somebody's father needs a surgery, but to get that surgery, they need a negative test. And there's surgery scheduled for next Tuesday, for example. Today's Thursday. There's no commercial lab that's going to guarantee that turnaround. So I'd have them come and see me tomorrow morning, and I'd get that test result for them tomorrow. Very commonly, there are people that are trying to get a nursing home bed or an assisted living bed or a memory care bed, and they're not going to be allowed in without a negative test. And again, those beds, there's a time window because there's pressure there. There's a line of people waiting for those beds. And so what I'll do is I'll get those people tested as well. And I think that's a worthy application of kind of a limited resource that we have. So we do
Russell,
those
you
things
have
on a pretty
about
regular basis.
8 minutes left. Unless we want to run on longer.
I'm easy. I don't want to waste y'all's time.
Oh, no, you're not doing that.
Not a waste of time at
This
all.
is fabulous.
But I hear your concern. So the place, number one, the place to start is a nurse on call, that number that I gave you. Okay. I will tell you that 2 weeks ago, we were all the way out to 1 week to get an appointment for drive-up testing. That's unacceptable, because it's a week to get there, and then if I've got 5 days turnaround on a test, or a week turnaround on a test, or we're back at that 2 weeks. What the heck? Stay quarantined for 2 weeks. Save the test. So we're back now at pretty quick appointment times. Until the labs started pulling back, until we had a recent limitation, we were running over 1,000 tests a day. So we're running 5,000 a week, and you could get next day appointment for drive-up testing. So that changes, that varies depending on what access we have for our commercial labs. But the nurse on call is the place to start, NOC. So call NOC, explain the situation. If it sounds, if there's a cogent need, what they'll do is they'll kick it up, and it'll get filtered to me at some point. But rapidly, within hours, not days or weeks.
I ask a question related to children. You talked about schools. I appreciate that. What about small children? I know there's like a distinction between the 5 and unders, and I don't know what's real, they don't know a lot, I guess. So
we
as
don't
far as
know a lot.
daycares, you mentioned a daycare, and so I'm wondering about the very young children, because you can't put masks on these kids. 1, 2.
No kidding. I don't even know if you can put masks on older kids. Heck, I hate wearing a mask. There are days. So the days that I'm out at the drive-up testing, and I try hard not to be out there. But then the rare days now that I'm out there, I'm wearing a full N95 mask, a full face shield, a full gown, and gloves. And it's over 100 degrees out in that black asphalt parking lot, and that's just killer. I mean, it's unhealthy, not at my age. So, kids. Yeah. So there's a lot of talk about children being an asymptomatic transmission vector. We don't really have great evidence for that. Okay. I mean, here in county, I can only think of one parent couple that were clearly infected by their kid. About a 5-year-old. But I mean, that's out of, oh my gosh, that's out of a lot. That's, more than 10,000 cases, 12,000 cases. So it's not common. But then the problem is, like you say, they're not going to wear masks. I don't even know if middle school or even high school kids can be relied on to wear masks. I mean, heck, I look around at adults, they're wearing a mask like this, and their nose is hanging out. They're wearing it on their chin or on their neck. I mean, come on. It's not doing anybody any good. But for kids, I think so we've been working with a daycare, and they wanted to open up again. And they have a national management organization. The one we were dealing with used to be independent, but now they're part of this huge national organization. And their headquarters is in Boston, Massachusetts, right? I mean, Boston Children's, that's like in the top 5 children's hospitals in the world. So they very wisely went to Boston Children's and said, listen, we need a pediatric infectious disease expert to help us work through this kind of this algorithm, this protocol for reopening our daycares. And then they brought it to us and I reviewed it. And frankly, I learned some things because I'm not a pediatric infectious disease expert, and they had done just a phenomenal job. I mean, just a spectacular job. And I use that as kind of the starting, the kickoff point, the starting point to help write opening plans for other daycares, other schools, etc. One of the things they were doing is they were cohorting the classes. So normally, if I'm running a daycare, you know, again, it's personnel flex time, because you know I've got people over here with this little group, and you know they're just in the morning, and so as soon as they all go home or get picked up, then I'm moving my personnel over to this group over here to help, you know, do project time and nap time and whatever else. You can't do that in the time of COVID. Those people that are with that group over there, they need to stick with that group and not cross-pollinate with other groups of kids. And they can't cross-pollinate with their other colleagues. They can't all hang out in the lunchroom with their masks down, having lunch across the table. That's within 6 feet. It's way more than 15 minutes. So that poses a huge challenge for daycares and schools, of course, and everybody else that has that kind of, you know, scenario. They just don't have the personnel. It's resource intensive. No matter where they are, they have to do screening as they enter the building. All staff need to be screened. They need to be interviewed. They need to have their temperature, no touch thermometer taken, or they need to use an app and do it, you know, on their way in. Okay. So the frustration we had was that even despite this daycare group, national group, having like the best, most rigorous reopening guideline, the daycare that we had the outbreak on didn't follow the guidelines. So they weren't screening their staff in the morning. They were moving their staff between groups. They weren't staying with a cohort. They had an outbreak. Bing, 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 you know, case after case. Like I say, everybody lies, you know. I lie. So I get a migraine maybe once or twice a year. 2 weeks ago, I came in on a Friday, and I just felt like absolute crap, and I was starting a migraine. And I come in the same door. We're reduced to one door. There's somebody there, you know, going down the list. You know, have you had any headaches? Have you had, you know, went down, and I said, no. I was just like, let's get this over with. I need to get into my desk and get my job going. You know, I got stuff to do. In retrospect, that was just stupid. Yeah, easily I could have been infected with COVID. It you know, it blew up into a full-grown migraine. I ended up going home early. But that was just idiocy. And so we regularly remind each other at county that this happens. We see it happen all the time. And we remind each other, you know, you don't feel right, go home, you know, wait for the symptoms to evolve if they're going to, or, you know, get tested as necessary. Anyway, but this is the challenge. Yeah, more than that, the challenge is, you know, wearing a mask has been politicized. Oh my God, you know, how insane is that wearing a mask is a political comment? It's just science, you know? So.
I will say that, just as a side note, that the organization I work for is international, and we work all over the world. So what I keep hearing from my colleagues throughout the world who are in developing countries is they're very sorry for us. They feel very bad because of the way that the situation is being handled. And because of the fact that they're used to a lot of these in Asia and Africa, and Ebola, and the mask wearing in Asia is very common. So they really can't understand our cultural situation, why this is becoming so problematic. And of course, they can't afford in some of these countries to let the situation get out of hand. So while they can't social distance in some of these places because they're extremely poor and the lockdowns are causing malnutrition and all kinds of things, food insecurities, they are actually doing a much better job in a lot of ways in their hygiene. And if they're educated, they follow the rules as best they can. And yeah, it is a shock to me too, how this has become the issue of the day.
Yeah, consider that South Korea had their first case the same day we had our first case in the U.S. And you know, just look at the enormous difference in outcome and how it was managed. I don't have a lot left to chat about, but I just wanted to know, tell me about the Rotary Club.
Yes.
And my observation is that it's good to see some youngsters among you. My observation is for Lions Club and Rotary Club and other community organizations, tends to be an older generation, and I don't see them being replaced by a younger generation. And the question is, what do you all do? And how do you see that challenge? What are you doing about that issue?
That's a very good question. Yes, your observation is pretty true. Most of the Rotary clubs was older white men. That changed. Women joined us, thank God. And they make a ton of difference in Rotary. Younger people are coming around Rotary, but not as much as we'd like. We are getting sort of the younger family age members joining, but it's still, if you look around the district, we have 52 clubs in this area, this district, and I would say a very large majority is still old white men, still very much the same. But that, as I say, thank God women are making a big difference. You see a big representation on the screen here. We have a lot of women in Rotary clubs, and they do a ton of the work. They are fabulous. And I'm not saying that because they're here.
I see. You just got them to do the work.
Yeah, exactly.
Very wise.
I would say it a little differently. I think we probably did get them in to do the work that they decided that they wanted to do, that we're now involved in. And one of the projects, as you obviously are aware, is ending polio. If it wasn't for the women that are involved in Rotary throughout the world, we wouldn't even be half as close to eradicating polio as we are, because women are part of us.
Yeah, and that's one of the, thanks for that subject pointer there, Lynn. I've been trying to get more information on the Rotary Club and polio in the world, and what we've been doing for years with polio vaccinations. And apparently some of the information I've got is it will lend itself in certain areas to a COVID vaccination program eventually. Because if it sticks around like you're saying, this thing will not go away on its own. We may have to have a polio-like vaccination scheme for the world as we do with polio.
Absolutely. And
The contact tracing.
I'm hoping that the multiple strategies to develop vaccines will give us vaccines that have lasting immunity, lasting protection. But the fear is that it'll be similar to flu, in that we'll need a regular booster.
Right.
It's not similar to flu in that it doesn't. I mean, the problem with flu is that it mutates so rapidly that, you know, there are multiple strains of flu around the planet every year, and basically, you know, the World Health Organization, the CDC, kind of monitor those and select 3 or 4 to develop their vaccine against as kind of the most common and most dangerous. SARS-CoV-2 doesn't appear to be one of those, although I have to say, when it started, when we first became aware, and first started sequencing SARS-CoV-2 back in February, there were none of this glycine at position 646 or something like that. But there's now a glycine mutation. I think it was asparagine became a glycine. No big deal. It's not any more dangerous in that it doesn't have any more severe of an infection.
But it was a change.
It's much better at infecting us. So it didn't exist in February. Now it is about 90% of the global SARS-CoV-2. That is, we're seeing this Darwinian selection for this strain of SARS-CoV-2 with it's called the G mutation, the glycine mutation. And basically it's taken over because it's just so much better at infecting us. And that's the scary thing about this virus.
Yes, it is.
It's unbelievably good at being transmitted person to person. So wear your mask when you're out and about, and maintain 6-foot social distancing.
That was for you, Barry.
Anyway.
Hey, Russell, this has been fantastic. And we could go on for hours here, but I think we'll let you go. And if you don't mind, I'm putting you back on my list for later in the year when this thing is still around and we need a fresher update.
It'll still be around years from now. This is the new normal.
Yep, I'm afraid so.
And I'll be sure to send you a couple things. I'll send you
that'd be good.
This one pager on testing, and then another one on kind of the risks of various things. So,
and if all of you on board tonight would make sure I have your email, I will send this out to you. And Russell, you'll see this if you want to look and see what you said. This will be on our site. No, it says.
You want to be reminded?
No.
Anyway, just for everybody else,
there's only one thing I hate more than listening to myself, and that's watching myself. Thanks so much again for the invitation. I really enjoyed it.
Many thanks, Russell. It was awesome. Thank you.
Great presentation.
Thank you.
Thank you.
Thank you very much.
For everybody else, the video will be out there if you want to go back and check some of the facts if you didn't write all the notes you needed to write. This will be out there, maybe not tonight yet, but first thing in the morning I'll get this completed and it'll be out there. If you go to the Farmington Rotary Club website, farmingtonrotaryclub.org, over on the left-hand side there's a library link. Takes you to the library of all the meetings we've had and recorded and publicized or published. This one will be out there, as I say, sometime early morning, and you can watch it all again.
Very good.
Okay, guys, we'll call it quits for tonight. And thank you all for attending. Thanks.
Thanks a lot.
And thanks, Peter. Thanks for staying with us.
No, it was very enjoyable. Thank you very much.
Okay.
Thanks.
Thanks, guys.
Take care, all.